Good afternoon, everyone. On behalf of the NYSCHP Education and Professional Development Committee, I would like to welcome you to this afternoon's webinar entitled Pharmacist's Guide to Clinical Pharmacogenomics. We are thrilled to have Dr. Aniwaa Owusu Obeng as a presenter. Dr. Owusu Obeng is the Senior Director at the Mount Sinai Pharmacogenomics Program. She's also the Associate Director, Associate Professor in the Department of Medicine at the Icahn School of Medicine at Mount Sinai. Dr. Obeng joined Mount Sinai in July 2013 and has been spearheading the clinical pharmacogenomics implementation program since. She's led the pharmacogenomics development of provider and patient education materials. She's a PGY1 and PGY2 rotation preceptor. She also precepts student pharmacists. Before we get started, I'd like to share a few quick points. For those who have technical issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist your resolution. For those who have questions you'd like to direct to the speaker, please use the question or chat option. The CE code will be provided at the end of this program. Without further ado, I'd like to welcome Dr. Owusu Obeng.
And thank you, Jamie, for the introduction. Welcome everyone to today's talk. Thanks to the organizers for the invitation to speak on this subject. I'm very passionate about it, so I'm excited to talk about how we all can, get into the space of clinical pharmacogenomics. So today my title is The Pharmacist's Guide to Clinical Pharmacogenomics. I do not have any relevant conflicts of interest to disclose for this presentation. The learning objectives are listed here for pharmacists, and I also have subset of that for our pharmacy technicians as well. So I want to start off with this statement from the American Society of Health System Pharmacists in 2022 that there was this statement on pharmacogenomics, and I'm summarizing it here, but basically all pharmacists should have a basic understanding of pharmacogenomics so as to provide or promote pharmacogenomics guided patient care. And in that statement from ASHP, they did mention a few roles of the pharmacist. And one of those roles were one, to recommend or order the pharmacogenomics test when appropriate, that pharmacists should be able to design and also design patient-specific dosing and drug regimens based on their pharmacogenomics results, that pharmacists should be able to educate healthcare professionals and communicate pharmacogenomic recommendations to the healthcare team, and in so doing, be able to document that and be able to interpret that information. And lastly, the pharmacists are supposed to be the ones who provide resources and education to empower patients. So knowing all of this, you may understand why a lecture like this is relevant. So let's take some of these roles in detail. So the first one here that I deduce from that statement is that as pharmacists, we are supposed to be students of this field. So how do we become students of this field? Well, why don't we start with a little bit of a history lesson here? So many years ago, in 510 BC, this is when the Greek scientist Pythagoras observed something when it comes to fava beans. He observed that there were individuals who would take this not medication but food, and they would not do so well on it, while majority of the people were doing okay. In fact, there were people that were experiencing what now we call hemolytic anemia from eating or ingesting fava beans. So his recommendation back then was everyone should be far from this fava bean consumption, because at that point we were not sure, or there was not a clear distinction as to why some people were experiencing the hemolytic anemia whilst others weren't. And this is known as favaism many years ago. But if you know anything about pharmacogenomics at all, or you probably remember this from pharmacy school, you can understand that this reaction was due to a deficiency of G6PD, or glucose 6-phosphate dehydrogenase. And this was only discovered more recently than what Pythagoras observed back then. We also know that G6PD deficiency is not only implicated in faveism, but also implicated with many, many medication interactions. A very common one being respiricase, which we know that in Sinai, Mount Sinai, for example, we routinely test for G6PD for respiricase therapy, right? So we know that there are many medications that are also implicated with G6PD. So, what is going on here? Why are we even concerned with this? So, let's talk a bit about genetics 101. So, I'm just borrowing these slides from the National Society of Genetic Counselors here. I think their slides for this topic really drives home the point. So, just some basic review of genetics. We have the DNA within a cell, but within the cells, you have your chromosomes, which everyone has 23 pairs of. Within the chromosomes are long spans of genes or genetic material. There are portions of that genetic material that encodes proteins, and then there are portions of that serve as instructions for those parts that code for proteins, which are known as the intronic regions, and then there are the exonic regions which code the proteins. But this long strand of genetic material forms the DNA for that individual. So over 3 billion base pairs within the DNA. Now, think of your human genome or the genome concerning you as an individual as a book that is written about you by nature, right? So, that entire book about you is your genome. Now, think of the fact that you now have 23 chapters within that book or 23 chromosomes. There are duplicate chapters, so you have 23 pairs of chromosomes. Now, within each chapter, there would be paragraphs or sentences. So some genes are really small. They only make up maybe 100 base pairs, and then there are some that are kilobases long, right? So there are some genes that could be like sentence structures, whilst others could be as long as multiple paragraphs. So within each chapter or within each chromosome, there are chapters which form the genes. Now, within each sentence structure, or in this case, the DNA sequence, there are variations or changes from one individual to the other. And those variations are what we call polymorphisms, especially when those variations occur in more than 1% of the population. They are known as polymorphisms. In the past, you may have heard it being called as mutations or genetic mutations. There's a negative connotation to the word. So in practice, we don't use that term, but we use the word variations or polymorphisms when they occur in more than 1% of the general population. But this is just an example of what a variation could do. So let's say the reference is the gray cat ran down the hall, but in the next individual, has been a change from an H to a B. In fact, in the DNA sequence, there are only four base pairs, the A, T, C, G. So there's not an H or a B, but this is just for illustration purposes. So there could be a single change of a single nucleotide, which can change the resultant meaning of the protein. So here, when it says the gray cat ran down the ball, it's a very different meaning from the gray cat running down the hall. This is just to give you an example of what these changes in the DNA could result in. Now, there are many types of genetic variants or variations. So there is the missense variants where there is a change that doesn't lead to a protein that makes sense or has the same activity as the original. Then there are changes that are like insertions, right? So instead of there being maybe in this case the gray cat is now saying gray green cat. So there could be an insertion of a single base pair or an insertion of a list or a string of base pairs, right? And then there are deletions. Deletions happen when the sequence has also been either there's a stop codon that would just stop the translation of that, or there's a portion of that DNA that's taken away. This is very, very common. And then there are also duplications as well, where a segment of the DNA gets repeated over and over again. And then there's the nonsense variant, where that segment of the DNA is cut short prematurely. So there's a premature stop codon that stops that sequence. So it doesn't even make sense. And you can imagine that nonsense variants almost always lead to a protein that is non-functional because it doesn't have all that information that it needs to actually translate the RNA into a protein. So these are just some of the common variations. There are others, but especially in pharmacogenomics, these are the variations that we are concerned with. So, in pharmacogenomics, just as in many other forms of genetic medicine or genomic medicine today, you hear the term SNPs or SNPs. These stand for single nucleotide polymorphism. This is when there has been a single base pair change in the DNA sequence. There are over 3 billion base pairs. And so you may think, well, when there's only a single change, why do we even worry about that? It's just a minor typo. Well, those SNPs or single nucleotide polymorphisms can inform a whole variety of things when it comes to the phenotypes, when it comes to protein activity, when it comes to cell signaling, and many other things. These SNPs are very common. I bet that out of the 117 people on the line today, everyone has a SNP. Everyone has a SNP. It occurs nearly every 300 nucleotides on average. There are more than 10 million SNPs in the entire human genome, and everyone has one. In fact, if you don't have one, you probably be the abnormal one, right? So it's normal to have a SNP. However, not every SNP results in a defaulting protein. So in this case here, from person A, there is the original is a GCA, which is the codon, the set of three base pairs. So GCA. But in person two, the nucleotide there is GCG. There has been a change from an A to a G. However, the resultant amino acid did not change. So it's still those two codons, GCA and GCG, both result in the amino acid alanine. So it doesn't change the resultant protein product. However, let's look at this from person two and person three, where there has been a change from an AGA to an AAA. This changes one amino acid from an arginine to a lysine, and that can change how well the protein functions ultimately. So that's why these single nucleotide polymorphisms are important. They can change how things are translated and what that results in as well. So these changes in the DNA are important because when we consider medicine and how we are using medicine today, we have this system called the trial and error, where every patient that comes into the healthcare system, once they are diagnosed with a certain condition, they receive a certain therapy. That's what we consider first line therapy. And some people do well on it, some people don't do so well on it. When it comes to treatment failure rates in the US, for every person helped, about between 3 to 24 individuals failed to show a response. And this is shown here in this chart, where in the drug aripiprazole, out of every 5 individuals treated, one of them do not have a response. For esomeprazole, you see that in 1 out of every 24 individuals, and so forth. So with this trial and error process, we are not doing so well when it comes to treatment failure rates. When it comes to adverse drug reactions, we also have a problem. So, adverse drug reactions account for approximately 6.5% of all hospital admissions in adults, and nearly 15% of all patients who have comorbidities, right? So, we need to do better when we are selecting treatment. And as pharmacists, that's where we shine, that's where we come in. We would like to tailor therapies to every individual to avoid these treatment failures and avoid ADRs. So the goal of pharmacogenomics is so that we don't continue this trial and error process, but we tailor or we personalize treatments to individuals based on their biomarkers, in this case, their DNA. So, what is pharmacogenomics? It's simply the study of how a person's genetic makeup or their genetic profile influences their response to medications. It can be in how well they respond to the medication, the efficacy of it, or with the toxicity. So, pharmacogenomics can also enable novel drug therapy discoveries and development. We can help to optimize drug dosing and choice of medications for every individual patient. And the ultimate goal of is to maximize efficacy and minimize toxicity. So when it comes to pharmacogenomics, there are two main concepts that we are interested in. There's the pharmacokinetics of the medication and the pharmacodynamics of the medication. If you remember from school, pharmacokinetics is the body's effect on the drug, which is the ADME process, the absorption, distribution, metabolism, and excretion processes involved in the drug disposition or the drug's journey throughout the body. Whereas pharmacodynamics is the drug's effect on the body. So, what we expect from the drug. So, with pharmacokinetics, we are looking at things like drug transporter proteins because that's how the drug gets distributed or taken from one portion into the other in the body. And we are also concerned with drug metabolizing enzymes. These are the proteins responsible for breaking down or activating, or even in some cases, deactivating the medication. So, drug metabolizing enzymes and drug transporter proteins are important for the pharmacokinetics. And with pharmacodynamics, we mostly are concerned with the drug target protein. So you can imagine that the genes that encode these types of proteins will be of interest in pharmacogenomics because if there is a variation in those genes, we can expect a change in how well the proteins work, right? And so that's where we are concerned with the variability or in efficacy and toxicity when there are changes in these genes. So first are PK genes of interest or the pharmacokinetic genes of interest. You may have heard CYP enzymes a lot whenever you hear pharmacogenomics, and you would be correct to be familiar with that because when it comes to pharmacokinetics and pharmacogenomics, cytochrome P450 enzymes or CYP enzymes are very, very important. So as you're seeing here, phase one enzymes such as CYP3A4, 3A5, 3A7, CYP2D6, CYP2C9, CYP2C19. These are very, very popular in pharmacogenetics. This is because they are involved in so many of our prescription medications. In fact, CYP2D6 is involved in nearly 25% of all drugs that are prescribed, right? Prescription medications. So this particular enzyme here is very, very important in pharmacogenomics, and it's important to know the 2D6 status of your patient. So collectively between 2C9, 2C19, and 2D6, you're looking at nearly 40% of all prescription medications. So if you look at any pharmacogenomic test, you would definitely see these three genes on there. So the genes bear the same names as the proteins, so I use them interchangeably here. So the phase one enzymes are involved in the oxidation, reduction, and hydrolysis reactions of medications, whereas these phase two enzymes like the UGTs, the NATs, acylations, the UGTs, those are involved in conjugation reactions, right? So sulfation, methylation, and so forth of the medications. So as we learn more about what pharmacogenomics is and the history of it, there are other roles that we are asked to assume in this space other than just becoming students. According to ASHP, pharmacists are supposed to become advocates for pharmacogenomics. So how do we do that? I want us to first look at a case report. So this is a case that happened in Canada, and the news outlet reported that the title here was "The Absolute Most Special Girl, 4-year-old found dead with father." Oh, sorry, I'm reading the wrong title. Codeine use while breastfeeding may be dangerous. So that was the news article right there. That codeine use while breastfeeding may be dangerous. And the reason for this was a mother who had just recently delivered was prescribed Tylenol number three, which is acetaminophen and codeine combination for post C-section pain. So the mom who was just given this medication for pain was taking it as directed by her physicians. And unfortunately, she found her baby feeling very lethargic after a few days. She told them, they were like, oh, maybe she's not eating well. Just wait a few days. Let's see what happens. And unfortunately, the baby passed away only 13 days after delivery. The baby was a healthy child at delivery. So this was unheard of. They had to find out what happened. So the postmortem toxicity testing revealed that the baby's blood concentration of morphine was at 70 nanograms per ml, where the normal would have been anywhere from 0 to 2.2 nanograms per ml. And even if the baby was being treated with morphine for any kind of pain, that therapeutic level would have been at 10 to 12 nanograms per ml. So the baby was found with nearly 7 times the therapeutic levels of morphine, and the baby had never been prescribed any morphine. So why did this happen, you may ask? And this is because the mom was found later to be a CYP2D6 ultra rapid metabolizer. And why did this happen? In with CYP2D6 ultra rapid metabolizers, because codeine gets converted into morphine in the body by the enzyme CYP2D6, ultra rapid metabolizers tend to convert too much of the codeine into morphine. Normally, only about 15% of the codeine that's ingested is converted into morphine, but ultra rapid metabolizers convert way more than the 15%. And the baby was being breastfed by the mom as described, as directed. I mean, so as a mom who is just breastfeeding your child and this happens, imagine the amount of guilt that the mother will feel. Imagine even the guilt from the healthcare providers. This particular case report and other case reports like that came together almost around the same, about 3 year period in 2013, 2016. 2013 was the latest time when the FDA did something about this. But prior to that, about 5 years prior, there was a series of case reports, not just in babies, but also in children post tonsillectomy and children post adenodectomies as well. So in 2013, the FDA issued a black box warning against the use of codeine for children of any age who had undergone tonsillectomies and adenoidectomies. This is not in my opinion, I don't believe this was the choice that the FDA had gone should have gone with. I mean, testing for 2D6 is available and people should be tested prior to using this medication. But because also maybe pharmacogenomics is not as widespread, and most we don't have a lot of professionals who are well versed in the space, maybe that's why they chose to go that route to add a black box warning. But that's part of the reason why we're doing this lecture today, to try and get more pharmacists aware of some of these consequences of not knowing these genetic implications. So this is one of the main reasons why I believe as pharmacists we should become advocates for this, because there are cases like this, not just with this baby, but many. There have been more recent ones in the news regarding DPYD testing and or non-testing that led to some deaths, one in Oregon and more recently here in New England. So we need to do better with these testing. So this is the reason for the coding, which I sort of explained earlier. But coding, about up to 15% of it is converted by CYP2D6, sorry, into morphine, and the rest are converted into non-active compounds. Codeine by itself is not an analgesic. It needs to be converted into morphine to get its analgesic properties. Codeine by itself is actually an antitussive. So if you need codeine for cough and you are a CYP2D6 ultra rapid metabolizer, you would probably be we would probably be concerned still. But if you are a poor metabolizer, then you should be fine on that, right? So this is the morphine, the pathway that shows that process. So another fact that I want to put out there is that actionable pharmacogenetic variants are commonly expressed in the general population. Once again, my bet would be that of the people on the line today, almost everyone carries at least one actionable variant. I'm not saying a rare variant. I'm saying a variant that if we knew something about it today, you would do something different about some of the medications that you are probably currently taking or ones that you may take in the future. So these are very commonly expressed. These are some of the percentages of people that carry an actionable variant in the Vanderbilt program. They saw about 91% of their population in the Mayo right study, and 99% in the St. Jude's population, 98.5 amongst their Caucasian patients, and 99% amongst their African Americans. In the Emerge PGX program, which Sinai was one of the sites for this, 96% of our participants carried at least one actionable variant. So these variants are very common. So you may also wonder, so if they are common, why are we not doing something about it? That would be my question too. Because the second fact that I want to throw out there is that actionable pharmacogenetic implicated medications are also commonly prescribed. So not only are the variants common, but the medications that are implicated with those variants are also commonly prescribed. And the reason for this is out of the about the 1,200 individual molecular entities approved by the FDA, 15% of them, which is about 180 medications, have pharmacogenomic information in their drug labeling. So one may argue, well, it's only 180 medications out of this number. Why should we be concerned? Well, you probably have a point there. And maybe even all 180 do not have actionable information. And you'll be correct. It's only about 84 of those medications, or 7%, that have actionable pharmacogenetics. And this was as of 2015. The number is nearly 120 now. But let's just stay with these numbers just to make this point here. Out of those 84 medications, which, like I mentioned, is a conservative number based on current evidence, um, those are the ones that have actionable pharmacogenetics, meaning that if you knew the genetics of the patient, you would do something different about that. And but however, all out of those 84 medications and out of the 4 billion prescriptions that are written every year in our outpatient clinics, those 84 medications account for 18% of all those prescriptions were in our outpatient clinics. So that's 720 million prescriptions for those 84 medications alone. So these medications that have actionable pharmacogenetics tend to also be very commonly prescribed. So here are some examples of some of the medications for your own edification here. So there are some anti-diabetics, there are anticonvulsants, antidepressants, gastroenterology meds, rheumatology meds, hematology and oncology medications, antipsychotics. There are some supplements, some antidotes, immunological agents, behavioral health, infectious disease, cardiology. So as you can see, some of your medications that we commonly, verify or even administer are seen here, and they span multiple clinical specialties. So even if you are not interested in learning everything about pharmacogenomics, I would advocate that at least for the clinical specialty that you practice in, find out which examples are actionable and know everything you can about those, because that's basically all we can really ask you for. We are not asking that you know the entire compendium of pharmacogenomic, actionabilities and their recommendations. However, the ones in your space, just know them and be able to advise other clinical team members on this. So the other role that I want to highlight is that we need to become clinical implementers. Not only should we be leaders and advocates for our patients, but we need to find ways to implement them into our clinical settings. So how do we do this, and what are some key considerations? First, you want to make sure that there is institutional or departmental commitment from leadership. I am very blessed to be in an institution that our leaders believe in this science, they believe in cutting edge research, and also my chief pharmacy officer is a big proponent for personalized medicine. So that helps a lot. I know if you don't have that sort of leadership, maybe coming up with some evidence about what has been happening within the space and maybe even showing some cases within your own clinical workflows, right? That you can advocate for your patients in that manner would help, and it really helps to cut down on any reservations and hesitations that you may confront in this journey of implementation. Also, you want to have program ownership. I'm speaking to a group of pharmacists, so I do want and advocate that pharmacy takes ownership of this. In many institutions around the world and around this country, there are pharmacists that are leading the space with for their health system, just as I'm doing so for Mount Sinai. So pharmacy can take charge of this. Of course, there are programs that are led by physicians as well, like Vanderbilt and maybe even Indiana and Duke, that we get to collaborate with a lot, and even in Mayo Clinic, where they all are led by pharmacists, are led by physicians. But this is the space where pharmacists should shine. We are the medication experts. We are the ones that should be taking the reins here and implementing this. So we should take program ownership and get buy-in from other end users like our prescribers. You should consider thinking of this. Is this a research protocol that you want to undertake, or is this a clinical initiative? At Mount Sinai, it is a clinical initiative, and we are doing this because we believe that if the evidence is there, why not use it? And if we have the infrastructure to test our patients, why not use that information to optimize patient outcomes? And lastly, you have to consider the infrastructure that's in place within your health system. Even if you don't have an internal lab, there are external labs or commercial labs that you can use, who will collect the sample. For us, we do saliva kits and we mail them to the patient's home. So they collect the samples, they send it back to the lab, we get the results. So you have to also walk through all these processes to ensure that you have the right personnel and expertise to guide you into having a successful program. So then who do you test and when? This is always a question that comes up. For our program, we believe that if the patient has a history of pharmacogenomic related adverse drug reactions or even treatment failures, or they have a history of ADRs or treatment failures to pharmacogenetics implicated medications, we should go ahead and test them. If they have immediate family history of that, so that applies to their parents, their siblings, and their children. So if they come in and say, my dad had really bad muscle pain whilst they were on statins, I would not prescribe a statin, or we will make sure that if they are getting prescribed a statin, since we don't prescribe, we will make sure that they also will get tested so that we will have that information on file to guide their selection of to the right medication. If the patient has been recently diagnosed with a condition that would warrant a pharmacogenetic medication, we advocate that they should be tested as well. If the patient has a high risk ancestry, so for instance, when the story of Plavix and clopidogrel with CYP2C19, we know that poor metabolizers tend to be individuals of East Asian ancestry and Oceanian ancestry. So if I'm interacting with a patient who's about to be given that medication, I would strongly advocate that they get tested, because the chances that they are poor metabolizers or carry a loss of function allele is pretty high. If the patient is polypharmacy too, the chances that they will one day take a pharmacogenomic medication is pretty high too. And if the patient just wants to pay for this and just want to know more, why stop them, right? So self-pay individuals, we don't stop them from taking the test. So this is a case that I want to throw out there, and we'll come back to this. This is AH. He's a 77-year-old East Asian male who presents to the emergency department for shortness of breath and severe chest pain. He's complaining of worsening upon exertion, and he can only walk up to about 3 blocks. He denies lower limb edema or pain, cough, abdominal pain, nausea, vomiting, diarrhea, or dizziness. His 12-lead EKG showed ST segment elevation. His imaging showed occlusions of the right coronary artery. This patient's past medical history is significant for CAD and STEMI 10 days ago. PCI stent was placed and the patient was started on dual antiplatelet therapy, aspirin and clopidogrel. He also has hyperlipidemia and hypertriglyceridemia, hypertension, type 2 diabetes, and a TIA a year ago. The patient smokes half a pack a day of tobacco, drinks a can of beer nightly, and denies any drug use. Okay, so why don't we talk about clopidogrel now? So clopidogrel is an antiplatelet agent. It needs to be bioconverted in a two-step bioactivation process to its active metabolite. So clopidogrel is a prodrug. About 85% of the ingested clopidogrel is converted by esterases into inactive metabolites. So 15% of the clopidogrel that is ingested is converted in the two-step bioactivation process into this active metabolite. However, the enzymes involved in that bioactivation process are CYP2C19, CYP1A2, CYP2B6, CYP3A4, and 5, and of course CYP2B6 again. But CYP2C19 is the main enzyme responsible for that bioactivation process. That's why we focus on 2C19. It's not the only one involved in that process. So when you consider CYP2C19, there are multiple types of phenotype groupings. There are the ultra rapid metabolizers, which are those that carry two copies of increased function allele, and then the rapid metabolizers. These individuals carry one increased function, one normal allele. Normal metabolizers carry two copies of normal function alleles. Likely intermediate and intermediate metabolizers, they have activity level that's less than a normal metabolizer, but more than a poor metabolizer. So they fall between that group there. And then there's the poor metabolizer group. These are individuals that carry two copies of no function alleles, right? So they have almost no activity. And these are some example diplotypes to consider. But when it comes to the case of clopidogrel, we are mostly concerned with these four phenotypes here: the likely intermediate, the likely poor, and the poor. Why? Because if you remember what we described with the bioactivation process, if you decrease the activity of the CYP2C19, most of the clopidogrel will not be converted into the active metabolite. Majority of it will go down the pathway of the esterases and get converted into inactive metabolites. So the individual will not benefit from the drug as they should, right? You take clopidogrel to avoid further clots, but you tend to see individuals within 30 days of even a stent placement, they come back with stent thrombosis, of individuals with STEMI coming back. So that's what we want to avoid. And these individuals are more likely to have clopidogrel not be activated for them. So they are more likely to have less production of the active metabolite of clopidogrel. So because of that, there are some recommendations from CPIC, which is the Clinical Pharmacogenetics Implementation Consortium. So the CPIC is a group of experts from around the world. We come together, review evidence for each of these drug-gene interactions, and then draft guidelines for them. So I happen to be a member of CPIC. I wasn't on this guideline per se, but you get to review some of the primary sources here. So according to CPIC, if you are an ultra rapid metabolizer or a rapid metabolizer or a normal metabolizer, you are okay to use clopidogrel at the label recommended doses for cardiovascular indications, especially in this case for PCI, ACS PCI. However, if you're an intermediate metabolizer or a poor metabolizer, the recommendation is to avoid clopidogrel and use an alternative, specifically for poor metabolizers. For the intermediate, the recommendation is to avoid standard dose clopidogrel. In the past, people used to triple dose clopidogrel or even double the dose of it, but it's the recommendation is not to do that. Just use the alternative, which would be prasugrel or ticagrelol. if you are using this for something other than ACS PCI, the recommendation is not as strong for the intermediates because there haven't been a lot of studies with that particular indication group. However, if it's for ACS PCI, that all the recommendations are strong. What we consider the non-ACS PCI indications are listed here. Things like peripheral arterial disease, stable coronary disease, following a recent MI. So these have to be outside the setting of PCI. Now, if you're using clopidogrel for neurovascular indications, then the recommendation is very similar. For intermediate and poor metabolizers, you should consider an alternative P2Y12 inhibitor if there is no contraindication, right? Definitely you want to avoid clopidogrel in these patients as well. However, you have to consider that the alternatives here would be ticagrelor and ticlopidine and not prasugrel because it's contraindicated in patients who have a history of stroke and TIA. See, this is exactly why pharmacists are needed because most doctors see, oh, I can't use clopidogrel, let me use prasugrel or ticagrelor. But as pharmacists, we consider contraindications and other drug-drug interactions and other things pertaining to the therapy more than the prescribers do. So I believe that this is why pharmacogenomics is a specialty that pharmacists should take very seriously. When it comes to the CYP2C19 allele frequencies, as I mentioned earlier, you're looking for intermediate metabolizers and poor metabolizers, especially for the clopidogrel example. So among East Asians or people of East Asian ancestry, about 46% of them are intermediate metabolizers and 13% of them are poor metabolizers. That is more than half. So more than 50% of East Asian population would be at least an intermediate metabolizer or a poor metabolizer. This is the reason why you would want to advocate for testing if they are being challenged with a therapy that they could be implicated with. Also, the Oceanian population, you're looking at over 90%. And this is the story. I'm not sure if many of you know of the lawsuit against Hawaii, the state of Hawaii against BMS or Bristol Myers and Squibb, which they won 820 million about 2 years ago for. And that was the reason why. We can talk about that during the Q&A if we have time. So maybe you'll be wondering, what about reimbursement? Are we paying for this test? We all know, as this graph is showing, that as reimbursement increases or as test coverage increases, the more tests are sold, right? So if patients know that the insurance will cover this test, if doctors know that the insurance will cover this test, then more of them are more willing to order the test because they don't want patients to be burdened with extra costs, right? So we know reimbursement is really important here. So coverage definitely impacts the test volume and usage. So what about cost effectiveness of pharmacogenomics? In this systemic review of about 80 studies, they looked at the cost effectiveness of these other genes that are listed here. This was between August 2010 and September 2014. And they found that most of the tests that they studied, 55% were considered cost effective. Most of the studies that they reviewed were cost effective. So 55% of them were what they considered cost effective. 16% were what they considered cost dominant, meaning it was way more favorable to test than not to test. Then there was also cost savings, 13%. So not cost effective was only about 11% of all the 80 studies that they reviewed for the systemic review. So overwhelmingly, I would say, even if you just say 16% of them were not cost effective or unclear, but overwhelmingly, most of the studies on pharmacogenomics have been cost effective. So there's no argument now that why are we paying for this? There's no benefit to the reimbursement or coverage of this, as we heard in the past from third-party payers. Now, when it comes to coverage in the US, the current state of it, we mostly model coverage after CMS, right? So CMS has these MACs or the Medicare administrative contractors. So these are the MACs across the US. And for majority of the MACs, they cover the pharmacogenomic testing. So MolDX is the first group of MACs that came up. So all the orange states here, they came together in August 2020. They agreed that pharmacogenomic testing is indicated when the medications that are being considered for use medically necessary, appropriate, and approved for use in the patient's condition. So they decided to not only just cover those single genes, but they decided to cover panel-based testing. And so far as the medication had implications with CPIC level A or B, which is the highest levels, or if the FDA had pharmacogenomic information in the patient's in the medications package insert. So that's where MoDS started. As you can see, in New York, we are with the Blues, the National Government Services, and currently that MAC does not cover pharmacogenomics for CMS. So I always say New York tends to be the last one to cover things. But fast forward to 2021 in December, Novitas and First Coast, so this Florida one is the First Coast, Novitas are the darker gray states, including Texas and others here. They decided to cover all of the medications that are listed here in addition to the MolDX. So as you can see, we were the only MAC that did not have coverage or does not have coverage even as of today. We have petitioned this MAC about 3 months ago. We sent a group of my colleagues and I from the states that are represented there have sent petitions to CMS to get this coverage done. But luckily, something called the biomarker testing legislation was also happening alongside this in parallel from the American Cancer Society. And in New York State passed this law in December 2024. So we happen to be one of the states that have the biomarker testing legislation enacted. And in New York, it went into effect April 1st, 2024. And the biomarker test must be cleared by the FDA. It must be indicated for an FDA approved drug. It must have a CMS national coverage determination and or a local coverage determination. So based on what they've done already with the other MACs, all of those medications are fair game for this New York State biomarker legislation. Or the medication must also have a guideline, which includes the CPIC guidelines. It's not just limiting this to only cancer medications, which is really, really great that the American Cancer Society was able to do that, to leave that legislation to be very broad and not only cancer focused. So this is where New York State also gets to have this. So last two roles that I want to highlight are the roles of an educator and the roles of researchers. I believe that as pharmacists, we should be educating others about pharmacogenomics. Just even this introduction that you've heard today, we need to talk to other healthcare professionals and the public about the impact of pharmacogenomics. We need to be able to provide resources and education that would empower our patients to make more informed healthcare decisions. We need to serve as the subject matter expert for clinical pharmacogenomics, especially in our specialties, right? And we need to start incorporating this information into the training of our residents and students, because the kind of medicine that our residents and students are going to be faced with is not the medicine that we've always been doing. We are in this world of AI now, and we are in this world of genomic medicine. We cannot ignore it in our training opportunities and in our training programs. We should also be researchers. We need to start designing and conducting more research in this space. Our residency projects should be focused on things like this to make our residents competitive in the market space, and also to make them ready for the kind of medicine that they will be practicing. We can do discovery research, we can do translational research, and just also actively contributing to the body of literature is really important. Case reports are important. As you saw, the impact of a series of case reports that led to the FDA changing the product label for coding. There are many things that we can do, even starting very small and then expanding. And then there are others like myself and other resources around, especially in the New York City area, that we can definitely help if you wanted to get into this space and learn more. We have partnered with Toro College of Pharmacy to offer a pharmacogenomics training certificate program for pharmacists. And this is the second year of its offering, but we hope to continue to offer that. So if you are interested, just be on the lookout for the next cohort registration of that program. So some questions that I wanted to ask, just some thought, you don't have to answer right now, but should a parent be able to order pharmacogenomics test for their child? At what age should someone get tested? Who should have access to your results once you have the results? And what other ethical concerns would you have before you even engage in pharmacogenomics tests? These are concerns that our patients have. I want us to already think about them and be proactive so that we can answer them when they come up. But in conclusion, I believe that pharmacists are vital to the success of this emergent practice. There are many commonly prescribed medications that have pharmacogenomic implications. There are resources available to guide you. Many early adopter programs are led by pharmacists or have pharmacists in key positions. Even those that are led by physicians have pharmacists in very, very important roles. And pharmacogenomics is already an integral part of pharmacy practice, especially here at my institution, and I believe in the near future everywhere else. So I want us to just do a quick assessment for this lecture. Does CYP2C19 impact the pharmacokinetics or the pharmacodynamics of clopidogrel? You can answer in the chat. I didn't put a poll, but we should have probably done so. Sorry, but I'm not sure if I can get to see the chat. But if you guessed pharmacokinetics, you're right. So it affects the pharmacokinetics because it's the bioactivation process, it's the metabolism of clopidogrel into its active form that it impacts. So, and now the second question is CYP2C19 a drug transporter protein or drug metabolizing enzyme or drug target protein? Okay, so if you said drug metabolizing enzyme, you'd be correct. Okay, so back to the patient. If you remember this gentleman, he comes back, he's complaining of dizziness, of worsening chest pain and so forth. So this patient is this patient a candidate for pharmacogenomic testing? True or false? Let me check the chat. Okay. Oh, I can see the chat. Okay. So is this patient a candidate for testing? You can type it in the chat. Okay. I'm seeing no, I'm seeing A's. Okay, so it's divided. I see some A's, I see some B's. Okay. All right. So B, A, B, A. Okay. So let me go back to this patient because the patient is an East Asian male. He's complaining of chest pain. He's already been put on clopidogrel 10 days ago. Right. And he's coming back with these same symptoms. He's definitely a candidate for pharmacogenomic testing. He has high risk ancestry. He's on the drug and it doesn't seem to be working for him. So you want to test this patient for CYP2C19. I think I sort of answered my second question. Which of the following PGX results would be the most valuable to manage the patient's chief complaints? Is it his G6PD results? Is it 2D6? Is it 2C19? Is it SLCO1B1? Okay, thank you. It's 2C19. All right. Okay, so lastly, the patient is found to be a 2C19 poor metabolizer, and his doctor wishes to continue his dual antiplatelet therapy at home. Knowing his genetic profile, which medication would you recommend? Would you continue him on standard dose clopidogrel? Would you switch him to ticagrelor? Would you switch him to prasugrel? Or will you triple his clopidogrel dose to overcome his poor metabolizer status? Okay, so I see B, I see C, I see B, C. Okay. So if you said B, you'd be correct, right? Because you also have to consider the contraindications. Prasugrel is contraindicated in active pathological bleeding, history of TIA if the patient is 75-year-old or greater, except in patients who also have diabetes and or a history of MI, and also if the patient is less than 60 kilograms. This patient has a history of TIA, so prasugrel is contraindicated. He doesn't have any of the other contraindications for ticagrelor, so ticagrelor would be the best bet. Okay, and the patient's age as well. So I will end the talk here and see if anyone has any questions at all. Thank you.
Thank you so much for your presentation. I have a few questions to ask you. So, in your experience, how common is the NAT2 fast accelerator tested with isoniazid?
How common is it tested is the question?
How common is it tested? The NAT2 fast
Oh,
accelerator.
it's not as common as we would like. That's probably the best answer to that. No, I don't think I see it a lot. In fact, most of the pharmacogenomic panels do not even include NAT2 on there. We have a very comprehensive one that does, but not all of the tests do include that. So yes, not as common as we would like.
Thank you. There's another request that if you can pull up their final case scenario on your screen for them to view it.
The final case,
Yeah, that last case you have.
this one.
Thank you. Okay, I'm going to go to the next question.
Sure.
So, at what point would you say that we would be able to test everyone to see which genomic variants we carry and open to the public?
At what points would we be able to do so? I think one, that's part of what we are doing now. So we don't even have the capacity to handle that. And I mean, from a resource and a personnel standpoint, right? Mount Sinai is eager to test every patient that walks through our doors, but we don't have the right um, team or expertise. We don't have enough of it, is what I should say, to even handle that level of information. So I think when we get a lot more people, especially healthcare professionals, learning more about pharmacogenomics, and I put this right there back again to pharmacists. Once pharmacists start to take this more seriously, and we are well equipped to interpret and utilize that information to guide the care of our patients, we would be positioning ourselves very well. The technology is there. Reimbursement landscape has gotten much, much better. Than what 12, 13 years ago when I was in the space, there was almost no coverage at all, right? But now there is a lot more coverage, and coverage is getting better as more people pay for this, as more third party payers pay for this. I think once the payment structure is ready and we have the expertise to use that information, we will be ready for a widespread adoption.
Thank you. And another question is, how are patients being tested? Are they being tested in an inpatient or outpatient setting?
Mostly outpatient right now.
Great, thanks. And then follow up to that, from insurance, would this be covered by medical insurance or is there another type of insurance being billed?
Medical insurance, yes.
Thank you. Another question is, how are genomic reports or results documented in the medical records?
Oh, very good question. So the medical record system, and that's one of the things that has to also be ready. So our EHR systems were not built to handle this enormous number of genomic information. We've had to customize a lot of it, but Epic is doing a really good job of adapting. And just as the other companies, I also think Allscripts is doing a great job in that space. Cerna has some work that they are doing as well. None of them are 100% right now, but they are actually catching up to this space where now they know that we have to build what we call genomic indicators now so that the information is not just there in a PDF format, but it's discrete values, so we can build clinical decision support tools on top of that information. So our EHR systems have to also evolve to adopt this and to help us out, but we are not 100% there. We do have genomic folders that we put this information in our lab folders and things like that, but not in a structured format as we would like. But I believe that all of that is changing.
Thank you. And when the results are available, how are the caution medications and foods communicated to the patient?
When the results are available, how do we communicate medications to patients?
Like the medications and the foods that they should be cautious about? How are
Oh,
those
okay.
communicated?
So in our practice, we do have pre and post testing visits that patients get to sit down with a pharmacist, telehealth visits, and we return their results to them that way. Patients get a copy of their results as well. We also have clinical decision support alerts built into our EHR system that when doctors prescribe certain medications and we have their genetic information for patients, the doctors get alerts telling them the best medications to use, the doses, and things like that. So we have an alerting system for our prescribers, and we also have the counseling platform for our patients. We've also developed a mobile application to return results for our patients. So it's a mobile app that patients can get this results in a very patient-friendly format for them as well.
Wonderful. Thank you so much. Thank you so
Thank
much, Dr.
you.
Owusu, for your presentation today. We really appreciate your time and your expertise. So
And
now
thank
for
you
the
for having me.